From Diamond Pharmacy and Optics, this is PodcastRx with Chris Bender. When he's not on the mic, Chris is a clinical pharmacist with the Office of Pharmacy Therapeutics and Integrated Clinical Services, or Optics. He routinely helps providers in correctional and long-term care facilities make better medication decisions to improve patient care. And we're so happy that he's sharing his expertise with you.
Hoping that today can be a real knowledge booster.
A classic Batman and Robin or Jordan and Pippin type scenario.
A full armamentarium of options that clinicians can choose from.
There's no better occasion than American Diabetes Month to dive into practical treatment recommendations for type 2 diabetes. Using the ADA's pharmacologic approaches to glycemic treatment as a roadmap, Chris breaks down his clinical approach to 8 of the most common glucose-lowering medications. We also discuss the pharmacist recommendation process, correctional environment concerns, and benchmarks for patient success. All this plus medication news and some fascinating trivia about the discovery of insulin. I'm Adam Campbell, and thanks again for listening. Well, hello, Chris. Happy almost Thanksgiving to you. I would assume that's when our listeners are going to be hearing this. It's going to be very close to Thanksgiving. How are you today, and how's the lead up to holiday season going for you?
Yeah, well, hey, Adam, happy Thanksgiving to all of our listeners. I'm doing well. It's a beautiful day here. It's getting crisp outside. I will certainly say that. So it's nice to look at, but it's getting a little chilly. As far as the run up to the holiday season, it's funny. I just started doing some Christmas shopping last night, and I'm like already feeling like I'm behind the 8 ball. I swear I do it every year, but yeah, it comes faster and faster every year. I'll tell you that.
Yeah. We see the decorations coming up earlier and all that. I think it just puts the heat on everybody. But
yeah, I feel like the day after Halloween, everything immediately changed. We already have neighbors with decorations up in their yard, and I thought, oh my gosh, it's already holiday season now. So it's fantastic, but it's also a whirlwind. Yeah.
Yeah, no doubt. Well, I'm glad it's going well for you. And I just wanted to say for this episode, for as much as we associate November, the month of November with Thanksgiving and this, advanced start of the general holiday season, November is also a big health observance, a big observance for the healthcare community, and that it's American Diabetes Month. And Chris, I know, given how much the optics team addresses diabetic care concerns in the correctional population especially, I think we'd be remiss if we didn't make diabetes care the subject of our main discussion today. So what do you think of that?
Yeah, absolutely. I think that's a great idea because, not only is diabetes a really prevalent chronic disease in America, and as you said, in the correctional space specifically, it has a bunch of potential negative repercussions. But the treatment of diabetes has also undergone a bit of a renaissance in recent years. So I think it's as good a time as ever to kind of dive into this topic.
And dive in we will. But first, we need to look at some medication news you can use with a quick trip into the clinic.
All right. Well, there have actually been a couple new drug approvals in the past month, those being Vlaylev and Orlynvah. We're really leaning hard into V's in drug names these days. So Vlaylev is a combination of foscarbidopa and foslevodopa that's given as a continuous round-the-clock subcutaneous infusion for the treatments of Parkinson's disease. Now, Vlaylev aims to address the biggest issue with Parkinson's treatment, and that being the concept of wearing off of medication effects throughout the day. So by giving it as a continuous infusion, Vlaylev actually increased the amount of on time or medication, or the amount of time the medication works throughout the day by about 2 hours compared to immediate release carbidopa levodopa in its clinical trial. So the hopes is it's going to increase the amount of time overall that patients get benefit from their medication. Now, Orlynvah, the other medication I had mentioned, is a combination of sulopenem and probenecid, which is used to treat uncomplicated urinary tract infections or UTIs caused by specific bacteria, so those being E. coli, Klebsiella pneumonia, and Proteus mirabilis. in adult women who have limited or no alternative antibacterial treatment options. So it's always great to have more options in an era where antimicrobial resistance is becoming more of a concern, but institutions will need to be judicious in its use, obviously, to avoid it too falling victim to resistance patterns. Now, in other approvals, Dupixent, which our listeners may know as being previously approved for asthma and atopic dermatitis, among other indications, is actually now approved to treat patients with COPD who also have elevated blood eosinophils, which, of note, is a sign of airway inflammation. Now, this is an important thing to note here because Dupixent works by mitigating the type 2 inflammatory response in the body via interleukins 4 and 13 inhibition. So essentially, the drug wouldn't provide any benefit to an individual without that sign of underlying inflammation. And this is going to be an important factor for providers to keep in mind moving forward. You wouldn't want to just put everyone on COPD on Dupixent. It's going to be more of a patient stratified or patient specific approach. Now, we also had some updated recommendations from the CDC regarding COVID-19 and pneumococcal vaccination. So the CDC now recommends that people 65 years and older, as well as those who are moderately or severely immunocompromised, receive a second dose of the 2024-2025 COVID-19 vaccine 6 months after their first dose. Additionally, those who are moderately or severely immunocompromised may receive additional doses, so like 3 doses or more, in consultation with their healthcare provider. And for pneumococcal vaccination, the CDC now recommends all adults 50 years and older receive a pneumococcal conjugate vaccine, those being Vaxneuvance, Prevnar 20, and Capvaxive, if they've not received one before. So previously, routine vaccination was reserved for those 65 years and older. So this kind of limits or this kind of lowers the bar.
And
finally,
sorry, Chris, I just wanted to give a quick plug just to continue what you were saying there, or to add some context to what you just mentioned there. That special bonus episode we did last month or so about 6 season vaccine updates. That's some good info to tack on to that if you haven't listened to that episode already.
Yeah, absolutely. As I was saying, Capvaxive, I was like, this sounds familiar. I think we've talked about this already recently.
Yeah.
And then finally, this, of course, being applicable to today's discussion, in the FLOW trial, oral semaglutide, which is sold under the brand name Rybelsus, demonstrated a 14% reduction in composite major adverse cardiovascular events. So it joins Ozempic, Trulicity, and Victoza as the GLP-1 agonists with proven cardiovascular benefit. So I think that's going to be more of a big player moving forward, particularly in those patients who would like to avoid injectable agents like Ozempic, Trulicity, and Victoza.
Absolutely. And we're going to talk a lot more about those things in just a bit. We're going to take a quick break. Stay with us.
Everyone knows that pharmacists dispense medication, but the clinical pharmacists in Diamond Pharmacy's optics team dispense more potent resources: information and education. The optics pharmacists are frontline medication experts for Diamond's many institutional partners. Whether you work as a provider in corrections or long-term care, the optics team is standing by to answer your on-demand medication questions. But optics is far more than a drug information hotline. They also create proactive knowledge resources like webinars and this podcast to keep partners up to speed with the latest drug developments. And they help providers to better manage costs and therapeutic outcomes with their in-house medication surveillance monitoring program. Learn more about the optics team by going to diamondpharmacy.com and clicking the clinical support tab. See pharmacy care more clearly with optics. Let's get back to PodcastRx.
All right, Chris. Well, as we mentioned at the top of the show, November is Diabetes Awareness Month. And Chris, big month for you and your clinical pharmacist colleagues in optics, as you all address many patient care questions in this realm. So I thought today you could explain how you use treatment algorithms to help providers with diabetes patient care, specifically regarding type 2 diabetes medications. And just for some context, when we're talking about the corrections environment alone, An estimated 9% of the incarcerated population has diagnosed diabetes. It's a number that's expected to go up due to an aging incarcerated population. My light went off. Okay. And increased rates of diabetes in younger people. And furthermore, the incarcerated population also features disproportionate numbers of people from minority or marginalized ethnic groups with disproportionate likelihood for diabetes. This info all comes from an American Diabetes Association statement from March 2024 titled Diabetes Management in Detention Facilities, a statement of the American Diabetes Association. And again, anything that we talk about today, Chris talks about, we will give you full show notes, links to those things so you can go and do some additional reading. But to kick off the discussion here in the main block, Chris, my first question, as a clinical pharmacist, where do you first get brought into the treatment process to consult with providers about what type 2 diabetes medications to use?
So in my position specifically with optics, it could really be at any stage of the care or of the treatment process, but it's often influenced by where the patient is located. So in the jail setting, patients are often coming in with an established diagnosis and a potentially short stay. So providers are in that location are usually looking for like a cost-effective treatment alternative, if they're looking for any alternative at all. Whereas in the prison setting, these patients are often there for a longer term, and they're being treated in more of like a chronic fashion, more typical to what you would see in the community. So for those patients, I'll get consulted by providers who have already attempted to get their condition under control and haven't had, may have had some difficulties, haven't had as good benefits as they were expected. So they'll often consult me at that point to kind of help them manage their condition a little bit better as it goes down the road.
Regardless of where you're brought in, then what are the first factors you examine as you're looking to make those treatment recommendations?
So it depends on whether the patient is just starting therapy or if they're currently on therapy. So for new starts, I really want to know the extent of their A1C and glucose elevations, their kidney function, whether they have any comorbidities such as chronic kidney disease, heart failure, cardiovascular disease, or if they're even at high risk, or even if they're just at high risk for cardiovascular disease. I also want to know the patient's weight and BMI and whether they object to injectable medications. Now, for patients who are already established on therapy, I still want to know all of those same things, but I also want to know if they've happened to miss any doses of their current medication, because that can obviously influence our thought process in terms of like changing medications, or if we need to change any medications, or rather if we just need to, promote adherence, as well as if they're experiencing any adverse effects of their medication. Particularly in my mind, I'm thinking like episodes of hypoglycemia or low blood sugar.
I know this is a bit of a big question here, but can you take us through the different glucose-lowering medications that are available out there and the steps that you take to recommend one over the other or in combination?
Yeah, absolutely. So, to be clear, there are a lot, and we could honestly spend probably like an hour covering them all in detail. And in fact, I have presentations where I do spend an hour talking about them all in detail. However, in this instance, I'm going to do my best to be brief. So there are what most consider to be 8 common medications for type 2 diabetes. And now these include metformin, SGLT2 inhibitors, GLP-1 agonists, the new dual GIP/GLP-1 agonist. We also have DPP-4 inhibitors, pioglitazone, sulfonylureas, and insulin. There are still a handful of others, like alpha-glucosidase inhibitors, meglitinides, and pramlintide. But honestly, these aren't widely used. And obviously, in the interest of time, we won't be discussing them here. So the key factors we consider when talking about diabetes medications, aside from, overt contraindications, of course, or patient-specific factors, would include their overall effectiveness, their risks of causing hypoglycemia, their effect on weight, and whether they have any benefits in cardiovascular disease, heart failure, as well as kidney disease. So starting from the top, metformin has high efficacy, low hypoglycemia risk, no effect on weight, and potential benefit in cardiovascular disease. SGLT2 inhibitors have intermediate efficacy, low hypoglycemia risk, intermediate weight loss effects, and some have demonstrated benefit in cardiovascular disease, heart failure, and kidney disease. Specifically, and I'm using generic names here for consistency and simplicity, canagliflozin and empagliflozin have benefit in cardiovascular disease. Canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin have benefit in heart failure. And canagliflozin, dapagliflozin, and empagliflozin have benefit in kidney disease. Now, I typically lean toward dapagliflozin and empagliflozin, those being Farxiga and Jardiance, simply because these two have the most broad benefit across indications and actually have FDA-approved indications for both chronic kidney disease as well as heart failure. So if you're only committing, if you only want to commit one or two per drug class to memory, those are typically the best ones because they're kind of like the Swiss Army knife of the SGLT2 inhibitors. Now, GLP-1 agonists have high to very high efficacy, depending on the agent that you choose. The older agents typically have high efficacy, and the newer agents, like Ozempic, tend to have very high efficacy. They also carry low hypoglycemia risk, high weight loss effects, and some of them, as with the SGLT2 inhibitors, have demonstrated benefit in cardiovascular disease and kidney disease. So specifically, dulaglutide, liraglutide, and semaglutide, both the oral and injectable form, are the ones that have demonstrated cardiovascular disease and kidney disease benefit. Now, I typically lean toward semaglutide, as it's available in both oral and injectable forms, as I mentioned in our prior segment, and it also has the highest degree of efficacy among this entire class. Now, tirzepatide is currently the only dual GIP/GLP-1 agonist on the market. Its profile is similar, obviously, to that of the GLP-1 agonists. However, overall, it's more effective in terms of glycemic control and weight loss. Now, because it's newer, it has not yet demonstrated benefits in cardiovascular disease or kidney disease, but it's really just the fact that it's only been on the market for so long. Those clinical trials take a long time to read out, and those clinical trials are underway. So if I had to guess, this agent is probably going to have those same benefits as seen with those handful of GLP-1 agonists as well. But again, time will tell.
And I do have to say, sorry, Chris, to interrupt again. I do have to say, if you want a bigger picture understanding of tirzepatide, do listen to Chris's earlier episode devoted to that topic. We did it earlier this year, and it's actually one of the best performing episodes we have of our podcast, Talking Tirzepatide, PodcastRx. So do go back and listen to Chris's discussion of that if you want to really fully understand tirzepatide and that dual action. Continue.
Well, it is the the GLP-1 agonist, and in this case, the GLP-1 agonist. They have, if there was a hot topic of the year and even the previous year, it was certainly that drug class. So that was probably one of the factors driving that episode. But yeah, I agree. That was it's hard to give full service to everything in a brief overview, but there's a lot to talk about with those ones. So I would highly recommend that episode, as you already have. So now we're getting into the therapies that are no longer as preferred, what I would consider, either because they don't provide those ancillary macrovascular benefits, like kidney disease benefits, cardiovascular benefits, or they simply have more undesirable effects than the previously mentioned medications. So the first of these is the DPP-4 inhibitors, such as alogliptin and sitagliptin. Probably the most popular one is sitagliptin, that being Januvia from a brand perspective. These are sort of neutral all around. So they have intermediate efficacy, they have low hypoglycemia risk, but they have no benefit on weight, the heart, or the kidneys. So like I said, they're just sort of like a very neutral medication used specifically for glycemic control. Now, pioglitazone has high efficacy, low hypoglycemia risk, and also has potential cardiovascular benefit this potential benefit was seen in the past in a clinical trial. It's not as widely known for this as like the GLP-1s and the SGLT2s, but it certainly has some benefit in that area. Now on the cons, it can cause weight gain, typically through fluid retention. So it can obviously cause or exacerbate congestive heart failure. Moving on to the sulfonylureas, good examples of those include glipizide and glyburide. These have long been used because they've been around. Obviously they've been around. They're one of the oldest drug classes for diabetes, but they've been so long used because of their high efficacy. But they also carry a high risk of hypoglycemia as well as weight gain. So those are two big things we try to avoid in our patients. And they also don't provide any ancillary macrovascular benefits. And finally, the old tried and true, that being insulin. This was the first and still is one of the most common therapies. There are multiple formulations of insulin. We have rapid, intermediate, long-acting. Now we even have like ultra long-acting formulations. And this is nice because it enables providers to tailor very patient-specific regimens that allows us to target hyperglycemia pretty much at any point of the day with high efficacy. So it's like very, very precise in that regard. However, insulin carries the highest risk of hypoglycemia as well as the highest risk of weight gain. It can be prone to dosing error, administration error, and doesn't provide ancillary macrovascular benefits like we've seen with some of the newer agents. So that was a lot, but putting this all together, I think that's the most important part to talk about is, if the patient has cardiovascular disease, or if they are deemed to be at high risk of developing cardiovascular disease, it's recommended to use either a GLP-1 agonist or an SGLT2 inhibitor with proven cardiovascular benefit. Or you could even use a combination of the two if their A1C remains above their target. Now, these options can be expensive, however, so a budget approach in this type of patient could possibly be to use pioglitazone, as I briefly mentioned before, just so long as they don't have pre-existing heart failure or weight concerns or anything like that. Now, if the patient has heart failure, it's recommended to use an SGLT2 inhibitor with proven cardiovascular benefit. Again, dapagliflozin and empagliflozin are those that I typically recommend here. If the patient has chronic kidney disease, SGLT2 inhibitors are preferred because of their robust data in this area. But GLP-1 agonists do have some kidney benefit, and they can be used if SGLT2 inhibitors cannot be used for some reason. It's just that GLP-1 agonists typically tend to be a little bit less effective in this area than the SGLT2 inhibitors are. But if the patient doesn't have any of those conditions, so we're not really looking for those overt macrovascular benefits, then we're more focused on overall efficacy from like a glycemic perspective and weight effects, which obviously would allow us to consider more options. So, for example, if the patient requires weight loss, it's preferred to use something with weight loss effects like GLP-1s or SGLT2s, but at the very least, we could use something that's weight neutral, like metformin or DPP-4 inhibitors, and we can rely more on lifestyle modifications to address the weight perspective there. Essentially, the idea is if you can't use an agent that promotes weight loss, at least use one that is weight neutral and won't contribute to additional weight gain that will allow the patient then to kind of like do more from a lifestyle perspective. Now, it's important to note that many patients will require more than one class of drug to achieve their goal. So these classes can be, most of these classes can be combined with some caveats. So first, GLP-1 agonists and DPP-4 inhibitors should not be combined simply because they work via a similar mechanism. interesting to note, the GLP-1 agonist works more strongly on this mechanism, which essentially makes the DPP-4 inhibitor an unnecessary agent, unnecessary cost. It no longer provides, it doesn't provide additive benefit. So once if a patient is on a DPP-4 inhibitor and then they start a GLP-1 agonist, that DPP-4 inhibitor can then be discontinued without any significant deleterious effect from a glycemic perspective as well. Another combination to use cautiously is sulfonylureas and insulin, obviously, since both of these carry a high risk of hypoglycemia. Additionally, because sulfonylureas essentially work by stimulating insulin release from the pancreas, they can typically be discontinued once insulin doses reach about 40 units per day, because at that point you're already giving so much exogenous insulin, squeezing the pancreas for whatever little additional insulin production at that point is almost moot. And finally, speaking of insulin, while it's not routinely recommended as much these days as it may have been in the past, it's still recommended as initial therapy if a patient presents with an A1C greater than 10, blood glucose greater than 300, or if they have evidence of catabolism, such as like unexplained weight loss. So that's kind of how I kind of conceptualize everything there from like a general overall workflow perspective. And then of course you have to keep in mind that this is a journey. It's not going to be a set it and forget it type of thing. So as I mentioned before, patients will often need multiple drug classes. This is just a really good starting point to kind of conceptualize which drugs you want to start with, and then you can kind of add on agents from there.
Definitely a lot there to cover, Chris. And on top of that, what kind of special considerations do you have to make when you're looking at treatment options in the corrections environment, whether it's security or just the overall correctional environment that very much differs from the community, obviously?
Yeah, so probably the biggest consideration is regarding insulin. So as I mentioned, there are multiple formulations of insulin, and namely, there are two types of mealtime insulin. So those are rapid and regular insulins. So rapid insulin works quicker. It's typically used 15 minutes prior to meals, while regular insulin, it takes a little bit longer to work, and it's used typically 30 minutes prior to meals. So one thing we have to think of is because of the time it takes to receive their mealtime insulin at MedPass, and then they have to go to the cafeteria to get their food, which can be somewhat of a delay between the two, it's actually not recommended to use rapid insulin in incarcerated patients. And instead, it's preferred that they use regular, and that's simply to give them enough time to get their food and avoid hypoglycemia. From other agents' perspective, there's no other real concerns that I've run into. Working in the correctional environment, you kind of have to think of things like safety and can things be used for other purposes and stuff like that. But diabetes medications, because of they're fairly benign in most cases and can't be used for other purposes. So really, the insulin consideration, avoiding hypoglycemia, is the biggest concern in the correctional environment.
I always have to ask you a sort of pharmacy nerdery question, but is there a diabetes treatment agent that of the many you just talked about that you're particularly fond of as a pharmacist?
Yeah, so I think it goes I think it goes without saying, I've always liked insulin because I think it's fun to track patients' glucose readings and kind of tinker and make their adjustments. Before all of the new medications came out, that was like one of the biggest roles that a pharmacist could play in diabetes care, was like making insulin adjustments. But from a clinical perspective, obviously it's not my favorite medication just because of the adverse effects and potential for hypoglycemia. So it's kind of like fallen out of favor a little bit. So I know this will make me sound like I'm a bit of a victim of the moment, but I really do like GLP-1 agonists and other incretin-based agents that they're widely referred to as that are being studied in the pipeline. I like them, of course, because obviously of how well they work for diabetes, which is pretty robustly, but I'm also fascinated at their glycemic effects. So obviously we know they work really well for weight. So we're seeing improvements in heart failure, sleep apnea, even like knee osteoarthritis, stuff like that, and other conditions that may be exacerbated by obesity. But we're also seeing potential benefits of these types of agents for liver disorders and even substance use disorders. So overall, from like the 10,000 foot view, I think the future is really bright for these types of agents.
Without a doubt. And so what are some treatment options outside the usual the 8 top ones that you discussed? What are some treatment options outside those usual glucose lowering medications that you factor in?
Yeah, so the number one treatment, obviously independent from medications, is a patient's lifestyle. In most cases of type 2 diabetes, this would include an emphasis on weight loss via diet and adequate exercise, which is typically recommended as at least 150 minutes per week of moderate intensity exercise, within the patient's physical capabilities, of course. From a dietary perspective, of course, we're all different. So a diet or an eating pattern should really be personalized to whatever works best for the patient. But generally speaking, it's encouraged to include non-starchy vegetables, whole fruits, legumes, whole grains, nuts and seeds, and low-fat dairy products, while also minimizing the consumption of meat, sugar-sweetened beverages, sweets in general, like candies and stuff like that, refined grains, and ultra-processed foods. I understand, from like a correctional perspective, the diet can often can be difficult to adhere to. So I often say, in my recommendations is typically to just like, hey, try to minimize the use of commissary, because commissary is kind of like the types of foods there are similar to what you might find at like a convenience store in the snack aisle and stuff like that. So even from a least case perspective, if we can minimize the use of that type of thing, like the snacks and stuff, you could kind of go a long way with that. And from a carbohydrate perspective, yes, these contribute directly to blood glucose levels, but it's not so much completely avoiding carbs as much as it is consuming the right kinds of carbs. So patients should minimize refined carbs like sugars or white breads and pastas. And instead, they should be looking more for like minimally processed, high fiber sources of carbohydrates like grain and wheat-based products. Also, patients should be mindful of their alcohol intake. This is from like a general community perspective, obviously, making sure not to exceed the daily recommended limit of 1 drink per day for adult women and 2 drinks per day for adult men. So that's like, the lifestyle kind of stuff, which is obviously the big thing. But additionally, more of like an ancillary pharmacologic tool that we have is all patients between the ages of 40 to 79 with diabetes should be on a statin medication, regardless of their cholesterol. And this is to reduce their risk of cardiovascular events. And this is straight from guideline recommendations. Now, it's interesting to highlight that younger patients, so those patients under the age of 40, they may qualify if they have evidence of diabetes-related microvascular damage, or if they've had diabetes for a sufficiently long time. So that's typically thought of as like 20 years for type 1 diabetes and 10 years for type 2 diabetes. Now, you may notice that the age range that I had mentioned was 40 to 79, but we know many people are still kicking above the age of 79. So older patients may qualify if they and their healthcare provider feel that the benefits outweigh the risks of taking a statin. And personally, I recommend starting or continuing a statin even past the age of 79 in these patients, so long as they aren't having any adverse effects from the medication. And that's simply because, in my mind, I typically believe the benefits outweigh the risks just from, the clinical data that is available that is not as robust as in younger patients, but there also has been evidence to suggest that when patients stop taking their statins above that age, they do tend to have more cardiovascular events. So as I said, in my mind, the benefits typically outweigh the risks.
Now, regular listeners know, Chris, that you and your colleagues do your patient care remotely. So with that in mind, what then benchmarks for success are you looking for then when you're following up on your treatment recommendations?
So just as a note from being remote, it can be difficult at times because you don't actually get to see the patient. So we have to keep that in mind. And from a remote perspective, we typically have to rely more on their numbers, more of like a pure analytical perspective. But as with any chronic condition, we need to be mindful that this isn't something that we will be able to fix in a day. So from a patient motivation perspective, we're really looking for general improvement and steps in the right direction. So has the patient's weight improved? Has their A1C begun improving? Has their overall quality of life improved? And like I said, from a remote perspective, that can be difficult, but we can impart that onto the providers, the boots on the ground, so to speak, the ones seeing the patient in person, because that's where that discussion happens. And you can at least reassure the patient that, hey, we are not yet at goal, but look at how far you have come from where you were when you entered treatment. And I think that's probably the biggest thing, because if the patient isn't feeling motivated, it isn't being recognized that they're making improvements, then they may not feel that they need to continue on with the treatment, because diabetes is a chronic insidious disease, and you may not always feel the deleterious effects of it, not at least until it's already too late, and then you've had the long-term sequelae of the disease, like neuropathy and retinopathy and stuff like that. But obviously, in medicine, we're guilty of liking hard numbers, goals, and thresholds. So we are looking to get the patient to their goal A1C, which can vary from person to person. It really depends on their age and their overall medical history. So for example, a younger patient with fewer complicating conditions, a little bit more motivated, they should be striving for a goal of less than 7. While an older patient with more complicating conditions, they may be a little bit more frail, they may be a little bit more prone to hypoglycemia, or they may just not have as much life expectancy, and we don't want to burden them with too many medications or going too hard. We may aim for a goal of less than 7.5 or even less than 8, particularly as they get up there in years. But, in reality, the ultimate benchmark for success in diabetes treatment is really the avoidance of diabetes-related complications. So we're looking to avoid nerve damage, eye damage, kidney failure, and even those cardiovascular events.
Well, that was a lot to get through, Chris, but thank you so much for the approach that you were able to take on that and bring things together so skillfully. And we could talk so much more on this, but I think that gives the listeners a lot to go on.
We certainly could, and I hope that was a detailed enough breakdown to give everyone at least a starting point. And if nothing else, just to prompt the listener to go to the link and we'll be providing, that a lot of that information is straight from the ADA standards of care guidelines. And in that, the pharmacologic, I believe it's section 9, the pharmacologic treatment of diabetes, their algorithm is really nice, really simple to follow, and that really can point you in the right direction with regard to what would be the optimal, first medication for a patient, depending on their comorbidities and stuff like that. So I would highly recommend anyone interested to check the link below and check that out for yourself.
In the realm of corrections health, not all electronic health records are created equally. Sapphire EHR is a comprehensive, cloud-based electronic health record designed specifically for correctional health providers. Since 2011, Sapphire has worked one-on-one with healthcare staff in jails and prisons to develop and refine a suite of features and modules to manage total inmate-patient care. From MedPass to dental care to documentation of lab results and creating custom forms, Sapphire's correction-specific features can be scaled to meet the needs of the largest correctional facilities down to the smallest local jails. And it's all backed up by 100% in-house hosting, training, and support. with a 24/7 help desk. Get a closer look at the Corrections EHR deployed in over 400 facilities across 36 states and territories. Visit www.sapphire-health.com and schedule a demo today. Sapphire EHR, cloud-based, compatible, correction-specific electronic health records. Now back to PodcastRx with Chris Bender.
With it being Diabetes Month, we wanted to end this November show with some fascinating history surrounding the discovery of insulin. And to add trivia on top of trivia, Chris, did you know that Dr. Frederick Banting, one of the discoverers of insulin, was born in November? I didn't know if you knew that or not.
How appropriate.
Yeah.
I did not know that, but that is awfully appropriate.
Yeah, very much so. So, of course, that's not as interesting as what you're going to tell us about. So carry on with that.
All right. So Canada is well known for many things: hockey, maple syrup, Keanu Reeves. But did you know that insulin is one of its most notable global contributions? Well, it all started in the late 1800s when researchers discovered that dogs would become severely and fatally diabetic upon removal of their pancreas. Now, this led to a frenzy of research that involved feeding or injecting portions of pancreas to animals and humans with diabetes to ultimately to no effect. But this didn't dampen researchers' enthusiasm as they continued to spend the next 30 years attempting to isolate that magical pancreatic secretion. That was until Dr. Frederick Banting teamed up with Charles Best in J.J.R. MacLeod's lab at the University of Toronto. In the summer of 1921, the two were able to extract insulin from the pancreas of a dog and inject it into a separate diabetic dog, successfully lowering its blood sugar. The two were able to simplify the process even further by extracting insulin from beef and pork pancreas from local slaughterhouses, much to the enjoyment of the local dogs. Their process and product were crude and inconsistent, however. That is, until James Collop, a biochemist, joined the team and improved the extraction process, removing toxic contaminants and creating a purer extract that worked more consistently and effectively. In January 1922, this product was tested with spectacular success on a 13-year-old boy who was on the brink of death from diabetes, who was in Toronto General Hospital, sparking a wave of enthusiasm throughout the medical community. The following year, Banting and MacLeod were awarded the Nobel Prize for their discovery, one of the fastest honorings of a discovery in the history of the award. So, in the spirit of Thanksgiving, as you reach for that second slice of pumpkin pie, give a small thanks to Canada, those researchers, and ultimately that little miracle peptide, insulin.
It's very fitting that Thanksgiving is following this discussion about, a disease state, so, closely linked to diet and eating. So yeah, that's a very good way to close that out.
That was exactly what I was thinking the entire time I was reading about this. So
well, we covered a lot of ground there, Chris. And again, I always want to thank you for making yourself available to take us through these often complex topics, but you don't make it seem so complex. Chris, thank you again, and look forward to talking to you.
Likewise. Take care.
PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as the substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services. Find our show on Apple Podcasts, Spotify, YouTube, or wherever you enjoy podcasts. And where possible, please rate and review. If you'd like to get in touch with the show directly, shoot us an email at podcastrx@diamondpharmacy.com. Thank you again for your support.